Good morning, everyone. Thank you for joining the Straumann webinar today. I am Eliza Schultz, Senior Director Product Management at Straumann North America. A couple of logistics items up front. So first, please type in your questions in the question field throughout the session. I will moderate the Q&A session at the end of the webinar with Dr. Elshar. And then the CE will be available to you via an email within 24 hours. It is my honor today to introduce to you Dr. Edgard Elshar, our speaker today, who will present current concepts in bone regeneration. Dr. Elshar completed his doctorate of dental surgery, his postgraduate education in advanced periodontics and dental implants, and received a master in oral biology from New York University. He is a diplomat of the American Board of Periodontology and Implant Dentistry, member and fellow of implant team of Implantology, ITI, and serves on the education committee, and member of the American Academy of Periodontology and Academy of Osseointegration. He is currently a clinical associate professor at the Department of Periodontics and Implant Dentistry, and the director of the Advanced Education Program in Periodontics at New York University College of Dentistry. Dr. Elshar was a former director and founder of Advanced Education Program in Periodontics at Lutheran Medical Center. He has a thriving private practice in New York City that specializes in dental implants and periodontal disease. Without further ado, I hand it over to Dr. Elshar.
Thank you, Eliza, and thank you for Straumann for hosting me. This is our second webinar. Some of the things we touched on last Tuesday, and we're going to continue the same, and then we will continue also next Tuesday. So thank you for coming. If you are the new ones, and if you are coming back again, thank you again for coming. It means a lot to me. So I'm going to talk to you today about the current concepts in bone regeneration. Okay, a second. Yep. So I like always to start with this question, and if you've seen me before, you will see that I do that all the time. And the driving factors in dentistry today, tomorrow, and yesterday, they were always based on this trilogy: implant dentistry, aesthetic dentistry, and oral health. So since it's a forum about implants and bone regeneration, one has to ask a question: if in order for us to place those implants in the most ideal situation, it will end up requiring quite a bit of things to prepare. One of them is ridge augmentation. Second is the socket preservation. And all of that will fall within the peri-implant health. This is the most important thing because we put the implants and we are looking for them in a long run. And also it depends on the way we place those implants. And all of this will lead to what we call the peri-implant health that makes it or breaks it. So it protects it against peri-implantitis, or if we do the implant not perfectly, we'll end up with complications. So that's the whole purpose of why it is important to review the bone regenerations, and then we talk a little bit about the latest and what we are doing. So if we go over what we're going to cover over this webinar, we're going to do a small review about the principles of bone augmentation and biomaterial review. And then I'm going to dive into the review of the flap management. This is for me very important because this is, we'll understand the concept behind how I treat my cases. And then I go over a couple of cases, and then next week we'll do even more. So having said that, let's dive into the principles of bone regeneration. So anytime we talk about bone regeneration, we are really covering 3 points: the biological basis of wound healing, the grafting material, and the surgical management. So when we talk about the wound healing, and everything starts with a blood clot. From that blood clot, we're gonna have a tissue modeling and remodeling, meaning it turns into granulation tissue, and from that it goes into the woven bone. And from that, it will end up with a well-organized trabecular and cortical bone. And that's what we have as a normal bone. So from that, I want to share with you the most fundamental study that has been done. And this study is the base of everything we do today. And it was done in 1994 by the group from Bern, from Switzerland. And Professor Schenk, when he did it, they took these beagle dogs and they created this U-shaped defect. And keep in mind, the U-shaped defect are the most difficult ones because you have no buccal and no lingual. And they put markers, these are the markers, and then they stabilized the non-resorbable membrane. And if you've been in this profession for a long time, you will remember the Gore-Tex membrane. That was the only membrane back then. And they stabilized them with screws, and they filled the gap, that gap inside, they filled it with blood. So to create a kind of a containment inside. And they did histology at 2 months and at 4 months. So if you look at 2 months, you can see this irregular formation of tissue. That's what we call today the woven bone. And if we look radiographically, and that's the most interesting point, is this. The bone came from the walls, and that's how it went, and they started bridging here in the center. Now, when we go for 4 months, you can see the more organized trabecular, but it was not completely organized because those trabeculation did not go from one wall to wall. And that's why we took it for us, and we see that people wait for 6 months for bone regeneration. And if you ask anybody why, they don't know the answer. Why? This is based on that study on Schenk. It was if this is in 2 months, this is in 4 months. So that one will expect that in 6 months, you will have a complete organized trabeculation. The striking thing is here. Look at this. You have this complete bridging from wall to wall, and that's the newly formed bone in the center. That's without any grafting material. The interesting point is the sites where that space collapsed, the membrane did not hold its shape, they had nothing. So that's how they postulated at the end that in order for us to have a successful bone regeneration, one has to have 3 points: space creation, space stabilization, and space maintenance. Some people call it the S3. So from that, let me share with you a clinical case that I did years ago. And that's a patient that presented to me with a complication, and that's how I unfortunately built my practice. So a practitioner placed an implant in position number 8 next to a 7 that had an endodontic problem. And when this infection blew up, you end up with what they call the U-shaped defect. It's exactly how the Schenk study. So we opened the flap. At that time, we went to the symphysis, and this is what we were trained in the early 90s when I was doing my residency. We did only the symphysis at that time, and then we did the retromolars, and we did the block. I mean, a huge difference from when we started in the 90s to in the 2000s, where you have a beautiful instruments like a piezo and so on. And then we take the block, and this is what I want you to pay attention to is this. This is the marrow. So anytime, and this is the cortical bone. So anytime you transport a block of bone with marrow, that is what's called, it has an osteogenic potential. That means it has the osteoblast transformed with it. If you are having only the cortical bone, and you can see tons of people talk about it, like shelf and stuff like that, this is only creating a space that is in osteoconduction. So there's nothing more than that. And they scrape the bone and then they put it, but again, how much you can scrape from autogenous bone? So as you see, we learned to put biomaterial, and then we covered them with resorbable membrane, and then we achieve primary closure. And then the most interesting thing is to follow the radiographs here and compare with what we saw in Schenk. This is at time 0. You can see the demarcation line between the block and the recipient bone. Then you see at 1 month how the resorption is taking place inside and how the bone is coming from the edges. And then in 3 months, you can see how the edges are filling and the center is getting a little bit lighter. And in 1 month, it was in homogeneity from side to side. And keep in mind, you can see also the amount of resorption that took on the head of the screw from day 1 to 1 year. So clinically, obviously, we have a beautiful bone, no question about it. And this is the theory at that time that came from NYU, and we refuted at this point, is placing one implant and cantilever off of it. The reason we refuted is because of the creation of peri-implant health risk with plaque accumulation. So this is a 20-year follow-up. It's a very acceptable result. You know, we still had some pink porcelain, but it's very well maintained over the years. So what do we have today? So we moved from the 90s all the way to we are 2020, although this 2020 has not been a great 2020. So we have this array of multiple biomaterials. It ranges from autogenous bone, that's the only thing that we have, and then you go from allograft to alloplastic xenograft to growth factors. There's tons of it. Really, somebody has to have such a grip on the knowledge to understand what he is using or what she's using in their own practices. So I want to start with the xenograft because that's when it came in the 90s. I was at the end, 96 when I was finishing. It was like the first thing. It was like a godsend product. And let's see what happens with it. So, you know, the bovine bone, it's a mineral bone, like all of the equine. So it is a mineral, so there's no organic in it because they sinter it, so meaning they burn it. And everybody tells you the temperature, and so when they burn it, there's no more organic features in it. And when there's no organic features with it, it never resorbs. So let me walk you through a couple of cases. And this is a case that I inherited in my practice from the gentleman who retired, Dr. Simon, lovely gentleman. And he left me this case, and he did a beautiful job by grafting the socket. So 10 years later, she decided to go ahead with implants. And so when I was placing the implant, I love histology, and that's how we were trained in my program at NYU at that time. So I took a core. And 10 years later, if you go on it on a higher magnification, the arrows will point to you the xenograft. So it's well circled with bone. Well, there's no problem, there's no question about it, but the graft is still there. Now you can see here in certain parts here, there's no bone around it, a kind of encapsulation. Now, when we look at another case that I did in 2000, and this lady had a root amputation at that time, and we grafted the socket, as you see, with the xenograft. And then down the line, her medical history has changed. She has a chronic lymphoma, so she can't afford having implants or any of that. So I told her we'll extract the tooth because decays happened, and that's what happens usually with root amputation. And then, because I have such a good relationship with her, I told her, would you mind if I biopsy that socket? And I did. And if you look at it, that's 18 years when I did it. You can see clearly the xenograft still there. And you can see well circumscribed bone around it, no question about it, well remodeling, good lacuna, but the bone itself is still there. And that is a problem for me. Again, I did another study on alloplasts. Alloplasts is the ceramics, and this is ceramics with collagen. And the way we did it is we published it in 2016. And when you look at the case, the way we did them is we took a fractured extraction or a fractured tooth. We did them on 10 cases, randomly chosen. There's not like only anterior or posterior, everything. And we took it out, we cleaned the socket, and we put the collagen ceramic, and we covered it with a resorbable membrane. We achieved primary closure. And then we took a CBCT at 6 months. You can see a well fill of that socket. And then at the time of the implant placement, we took a core of the graft, as you can see here. And in this one, and we placed an implant, and then we submitted them to histology. And you can see at the time of the placement, yes, you can delineate where the graft is. But if you look at it clinically, it looks solid bone. So when we look at it on a histology and we look at it on a higher magnification, you can see they act like a xenograft. You can see the particulate, and you can see bone deposing. And then don't forget, we took the graft in the center of the socket, which is the one that takes the longest to fill, and still the graft is there. And that's another thing similar to the xenograft. This is again another 2 grafts in that site. So, and this is a 6 years follow-up. I mean, the implant is maintaining itself, but if you inflict on it a peri-implantitis, so you know the bone resorbs, so that bone that deposits around it, either is it xeno or it is a alloblast, you're gonna see that the particles will become encapsulated, which becomes a harbor for more bacteria. This has been reported in JOMI and multiple other articles. So that brings me to the allograft. And I did a study on allograft in putty, and we published it again in 2013. Now we have to keep in mind, back then, it was still new to do histology for sockets, because this is one of the most difficult defects. And if you look at it, this is a tooth that is fractured, and we went ahead and there was bone loss on the buccal, a good interradicular. We placed the putty in, we covered it with resorbable membrane. But when we did the histology, it's very important to see where the harvest was done. It was done 2 of them, meaning in that socket and this socket, not in the center, otherwise we will skew our results. And then we looked at the histology. And when we look at it on a higher magnification, you don't see particulates. You see a remodeling, you see a good activity, the lacuna is all filled in, and look at the osteoblast lining up, and look at the osteoclast in here. So that's what you see with an allograft. It's a good remodeling, good change. And even if there is some residual graft, this will go away with time. This is part of the residual. Look at the lacuna is getting some remodeling in it. So again, this is the huge difference between an allograft versus a alloplast and a xenograft. So the question is, what should the clinician do? This is, we are here and we have to ask ourselves. Should you stay with the same in the mentality of the 90s and stick with the alloplast and the xenograft, and our colleagues in Europe, unfortunately, that's what they have, or you move forward and you decide to choose to transform and then go ahead and do allograft. And I want to talk about mineralized bone, particulate mineralized bone. So in the literature, Dr. Froome at NYU did a beautiful study comparing the xenograft to cancellous allograft in a symmetrical bilateral study, which is very important. And they found twice more vital bone with the allograft, less residual material, again, with the allograft. So that's a huge improvement. In a dear friend of mine, Dr. Bakri, he did a beautiful report. He's an oral surgeon, and he was treating the cleft. And he ended up, instead of using iliac bone, he used the allograft. And he said that the results with it were so impressive that it can change the whole pattern of an outpatient setting. So instead of putting them in hospitals, we can do a procedure in our own offices. So that's a huge transformation. And my study that I did, we get also 44% vitality of bone. It's a good amount. And also with Nevins, also in one single sinuses, in a cancellous cortical mixture, 50-50. So I may walk you through this case, and this is a canine that was fractured, part of a bridge, long span bridge. So when I raise the flap here, you can see there was nothing there, and there was also buccal plate loss. So there is 2 ways of doing it. You can follow the user and you can let it heal, let the soft tissue heal, and then go back and place an implant, or you can do it at the same time. So, but I published a paper on the roadmap and the protocol, and this paper, in it, I defined grade 1, grade 2, and grade 3. The most important thing is I looked at the buccal plate, I looked at the interproximal bone, and I did a look at the apical topography. And when we look at this, you can see that it's important because this is how we can define, do we have buccal bone? You can't call it type 1, type 2, type 3 because this is not a periodontal defect. Do we have interproximal bone? But this is very important because this is where you have the papilla. And thirdly, the most important point is the apical topography. And do we have a concavity on the apical? Because this is where you're going to place your implant. So if you go more lingual, you're going to tilt the implant towards the buccal. So again, this is another thing to take to look at. And also, I defined the biotype. and that was very important for me. And now if you look at the new classifications that came in the periodontology, and everything is based on biotype, and biotype is extremely important. If you look at the Journal of Perio of March 2020, it's extremely important, and I encourage every orthodontist to read it, because they're telling you without any hesitation, if you have a thin biotype, you're on a higher risk of recessions, and even also to place implants. So again, so the fact of having a phenotype defined is very important before you go ahead and you decide what kind of technique. So in that case, it is a grade 3. There was more than buccal, almost the whole buccal plate. And when you have almost the whole buccal plate gone, that's more maybe ridge augmentation. But in this case, I was able to place an implant based on the classification of Kahn, which is a W, as long as it is confined within the walls. If you can see, you have a wall up here and wall up there. So that is a good confinement for the graft. If you have a flat bone, meaning the proximal bone is here and here, the chances of having bone regeneration is almost none. And that's why the importance of reading that paper from Dr. Kahn. And here we did this sandwiching, which is a cancellous covered on top with cortical. I don't use a mixture. Cortical is almost down below within the walls. And this is where the blood clot, you can see how it soaks the bone, and then on top of it, a cortical bone that is more mineralized. It preserves the volume and doesn't resorb fast, and that's what you are trying to achieve. And that's what you see with Professor Buser when he talks about placing the implant and he puts the bovine on top of it, is the purpose to create volume. Well, you don't need to use bovine because you can use the cortical bone, so you can sandwich it. And here I placed my membrane. This is a resorbable membrane. I tack them. We've been tacking at NYU since the early 90s. This is not something new. It surprised me when I hear some new incomers that they talk about bone regeneration, they talk about tacks, and this is their own thing. This has been done with us from the early 90s. And then we achieve primary closure. So when we look at it at 6 months, look at the bone. I want you to see not only the buildup of the bone, but look at the vitality of that bone. It's vital. There is blood circulation in it. That's extremely important. And this is not only one case, a draw of a luck. This is repetitive. It happens all the time. And then I did my second stage. I do it differently now, but nevertheless, we will show you a couple of cases at the end to show you how to do it. And then this is a 10-year follow-up. And this is also when the BL just came out from Straumann. You can see the stability of the bone all around it. It's very impressive and very stable, and the volume is still stable, and the aesthetic is very good. So let me share with you another thing. This is a case where we had a fracture of the central, and you can see there is a space discrepancy, direction of the root that is not adequate, and we have mainly and most importantly the loss of the interproximal bone. So when we look at it clinically, and you can see it, the tooth, the dimension of the tooth are wrong, and most importantly is when you look at it in a close-up, you can see that they the crown that they did, they changed the topography. Look how thin it is. This is a triangular and square shape. So this is a very thin biotype. As long as, when you have a restorative, you have to look at the natural teeth. Very thin biotype, loss of the interproximal bone. Look at the purulence that we have. And then we have, this is not a normal socket. A socket, always you have two floors for it. One is the bone, and one is that gingival cuff, which is the gingival scallop. And that's what we call the biological width. And that's very important. So you can't only think in a socket, only bone. You have to think about it, bone and soft tissue. It's very important to differentiate. And that's why really it affects me when I see people talking about type 1, type 2, type 3, and stick an implant, and somehow the holy water from St. Peter is going to come and it's going to grow the bone. It doesn't happen like this, because this is a very thin biotype. This soft tissue is going to collapse, and aesthetically, it's going to be a nightmare. So moving along with it, this is what I call the grade 3. And in grade 3 here, I went to the part here where I use the soft tissue concomitant at the same time with the grafting of the socket. And this is a paper that we published in 2017. And this is a modification of the rotated palatal pediculated connective tissue. People before me have written on it. Dr. Khoury from Germany, they published on it, but again, we did a modification on it. So if you look at it, the modification is that we don't go from the margin of the socket, but rather we go from the distal of the lateral, and then we de-epithelialize all of that, and we get a connective tissue. You don't have to make a vertical here, but you need to do a trap door in here, and then you get your connective tissue, and you flip it over, and then you stabilize it over the socket. You don't need to tack it underneath because this is where the bone is going to be. So the bone is going to be here. That is where your housing of the soft tissue. And let's go look at it clinically. Now, when you take the crown off, you can see the amount of the fracture, the destruction that you have, and this unsupported papilla. So if I do only bone or I don't do anything, this whole thing is going to collapse and migrate more apical. So sure enough, this is the extraction was done, and I measure the mesiodistal and the baculingual, and then I go and I measure back. So I want to tell you, this is a before the modification that I did. So you can see we used to go all the way up to the gingival margin, but I wanted to show you this case because it has a long follow-up. And then you can see that we get the connective tissue. Again, this is the incision, this is the connective tissue, and then we placed it over the socket. So now we built what I call double decker. You have a bone here, and that's the soft tissue here. So you have two stages for one socket. We do a temporary fixation, meaning the temporization is a fixed temporary. You cannot do a removable on those cases. And I do usually give more space in here. A reason I do give the space because you don't want to put any pressure when that soft tissue expands and swell up. And it will. If you put a lot of pressure on it, you will necrose the graft. And sure enough, after healing, you see the scallop is obtained, and we have preserved 90% of the papilla. And this is what I wanted to show because that's going to be the entry into the new. This is the original Gonix table, we used to call it. It's the co-diagnostic that Straumann has, Dental Wings, and it is really phenomenal software. But this is way back in the time when we used to be able to make our own guides without printing them like we do right now, but rather we do them from models. And this is where the accuracy was not as 100%. And you see now with the digital is way much better, but I like to put it because that's how we progressed with time. It's very important to know where we started and where we are today. So we placed the implant digitally, we put the sleeve, and then you can go and mill that guide and you place the implant flaplessly, obviously. And unless you need to add more bone on the buccal. And sure enough, we placed it. We followed the norms of the ITI, and then we put a healing abutment on it. And this is the soft tissue when it matured, and we went ahead and got the final restoration. Now, definitely today I will do it differently. I probably will temporize at the same time. We can take advantage of the digital as we showed on Tuesday. We can plan it completely and synchronize with CARE software, and we can put a temporary crown or a healing abutment at the same time. But again, you have to put back yourself in the time, and everything has evolved, and that's the beauty of what we do. But for this case, it is a great success. So you can see the bone around the implant, the crown when it was placed, and then he moved to Chicago, but he's still kind enough that he asked his dentist that he's following him, that send me this x-ray. I got a 7-year follow-up. Now we are at almost 10. It's time to get another follow-up on it. But if you look at it from where we started to where we ended, and that's what I want you to look at here, that interproximal bone, and not only that, the sliver of bone that we have between that root and that root. It's very important. So if you take a chance and place an implant immediately, you will be probably in trouble. And one more thing that I missed telling you, you've seen the nasopalatine is very extensive on the lingual of that socket. Again, it's very important to read the cone beam beforehand. So how can we improve our communication and pre-surgical treatment planning in today's digital world? On Tuesday, I spent quite a bit of time on how I prepare my cases and how we take advantage of the digital, especially in the world of the coronavirus, and which we can avoid a lot of the saliva transmission by using the digital world. So let me walk you through this case. This is a case that has a socket that was grafted and it failed. Unfortunately, it can happen, and they did the same thing. It's just they put bone in it, and you can see that there is loss of bone here on the distal of the mesial of the lateral, and you can see this big granulocyty here. So when we look at the scan, you can see that there is a problem on the lingual, obviously, and this is the nasopalatine, but nothing until you look at the rendering. And that the problem with the rendering is you look at it on the scan, you cannot touch it in your hands, you cannot even communicate it with the patient because they cannot see anything. But the most beautiful thing is when you print it. So this is the time when, before the co-diagnostic are reconnected with it, we used to go through a third party, and there's plenty of these softwares that you can allow you to take a DICOM and turn it into an STL. And that's what is so important to understand the difference when we are dealing with digital. Digital is a language, and that's very important to remember. It's a language, and the language is STL. So you take an image, it's an STL. But if we are, and this is how you can print it in 3D. But if you want to have a DICOM, which that's what we have, how can we turn it into an STL? And that's where the trick. Now with the co-diagnostic, it's a press of a button, it takes the rendering and can export it as an STL. Even the cost of it is nothing that important, but the benefit of it is huge. For instance, look at this nasopalatine. It is very extensive, and you can see that if I want to do any grafting in that side, unless I deal with the nasopalatine, I will be not successful. And secondly, the most important thing is when you are planning for the case, you're going to see how much bone you're going to put and where is the location of the future implant. If you are like me, prosthetically driven, meaning you want to get it to be able to have a screw retained crown, that means the implant has to be partly here, partly there. So you need to build that lingual bone, and that's important. But in order for you to build it, you have the nasopalatine that expanded into the space of the socket. So this goes back to my roadmap, and in that roadmap, I go for ridge augmentation. So the tooth has already been taken out, the graft was done, it failed, so it's already the soft tissue has healed. But that will bring me to a very important point, is how we're going to manage the flap. So that's how it presents, and that's what I want to take a few seconds and talk about that. That's very important. It's more important for me than only going through the cases, because that explains the theory behind what I do. So if we look at the literature, anytime you do a flap, there is what we call a retraction. So that's why you see you put the graft and then you bring the flap over it, it is retracted. And not only that, when you put the flap over the graft, it will retract. And that's why you hear people talking about a passive flap mobilization. So that's because it is part of the healing. So it starts with early, late, and at the end it contracts. And the stabilization of the flap is extremely important. That's what we could also find in 1990, that if you don't stabilize the graft, the regeneration underneath it will not take place, like in GTR, and you end up with a long junctional epithelium. Same thing with what we do in ridge augmentation. Also, the suturing depend on the time. So if you don't secure them very well, you can see that the forces can break it. And you have to have a very well secured flap. So the flap is going to contract, you're going to hold them with good suturing, otherwise it will break off. The flap management. So if we look at the flap, it's the same as we are doing soft tissue. It's not that much of a difference. Back in the time when Dr. Langer from New York, one of the most sophisticated periodontists I've ever met, and he did this flap, and you can see he described it with vertical incisions. And today we don't do that. You can see there has been an evolution of the flap. And the reason behind it, if we look back in time, about Mormon in 1977, and this is when they did the vertical incision. Immediately, after the incisions were made, they looked at the angiograph and they found this darkness. This is the lack of blood supply. If you look at it within 24 hours after the surgery, look at the amount of necrosis that takes place. And that's why I do not do any vertical incisions in my flap. So moving along, you can see that Bruno in the 90s, 94, he also did the same thing. He didn't do the vertical incisions, but he did an incision, what we call it, the butt joint below the papilla. Later on, Zucchelli, a very well-refined surgeon from Italy, he did differently. He said what we call a papilla sparing. What does it mean? He slices the papilla, and by that, you leave the papilla anchored into the bone, and then there is not any risk. So the reason behind those things now, first of all, we talked about the flap, we talked about the incisions. Now we're going to talk about how to manage the flap. I mean, a lot of people, you can see them, they take a blade and they cut into the flap. Or they talk about periosteal or slicing or splitting and all of these things. The most important is to go back to the fundamentals. Now, if we look at a flap, when we look at it and we look carefully on a higher magnification, you can see that the flap has a supraperiosteal artery. So if you cut into the flap in order to release it and open it, what you're doing is you're cutting the blood supply for the flap. Now, why do we need to do it? So usually you can see most of the people, they do incisions, they do vertical, they lift, then they come to passivate the flap. The flap doesn't move because you have a vertical incision 1 or 2, and then the flap shrinks. So they go and they do these incisions inside the flap. When you do that, now you shrink it even further. So that's why, but we look at it at the flap and you look, there is 2 parts to it. There is the keratinized tissue, that's the mucogingival line, and then there is the mucosa. And in the mucosa, there is tons of elastic fibers. So we don't need to do any incisions inside. Actually, the flap is elastic, meaning it will stretch with you because 60% of the mucosa is made of elastic fibers versus here, it's more collagen. So it's a huge difference because the need for the keratinized versus the need of the mucosa is totally different. And if you cut into the mucosa, there's a lot of blood supply. There's a reason why you have elastic fibers. So let me walk you how I do my incisions. This is a scenario like this. It can be single or it can be multiple. I do my incision intrasulcular. I slice my papilla intrasulcular. I stay more towards the buccal. Intrasulcular, again, slice, intrasulcular slice. And here I come up to the line angle on both sides. Now, this is how you raise the flap. This is the papilla. The papilla is still there. Or you can, and this is where we do the elevation. Now today I can do, and I will show you in the case, I do a little bit more of 2 here submarginal to get more retraction, because now we learned about this presence of this nasopalatina and an impediment, how to deal with them. But let me talk to you a little bit about, that's the other scenario that I showed you, no vertical incision whatsoever. So this is what we call the papilla sparing. You can see it's the slicing. It's important to see the papilla here. The papilla is still anchored to the bone. Why is it so important? Because the blood supply comes from here. If you elevate that papilla, then you're going to have a shrinkage of the papilla. But if you don't touch it, you just slice the outer layer of it, it's a pyramid. It has multiple surfaces and still attached to the bone. That is so important. And that's what Dr. Zucchelli from Italy has shown in his flap management. I do it more towards the buccal, the incision. And there is a reason for that, because now I put my bone, I lay my membrane over, and you can see I tack that membrane, tug, or I can tack it under the lingual flap. And now I go past the mucogingival line, I stretch the flap, and then you can achieve. The closer you have here, it's better than having it here. That's 1. 2, the blood supply here is very minimal because it's more keratinized here versus the flap here. So these are the principles. So let's go back and review this case. So I do my intrasulcular, and we do the slicing. We do the full thickness flap. Again, this is the lingual that I talked about. I elevate completely. And now I use the Straumann ring. And you can see this is the technique that it works. And this is how it presents itself. It's an allograft. You place the implant at the same time. And sure enough, this is how I placed my implant. Again, prosthetically driven. I put a membrane, two membranes, lingual and buccal. These are 220 by 30. I tacked them. I filled with a cortical bone, and I did a stretching of the flap. You can see how we do here, the suturing. This is at time 0, and this is at 8 months. Now at second stage, I wanted to improve the soft tissue. I went more to the lingual, get some more soft tissue, and you can see how the bone grew under the fixation cap. And then I exposed the implant, and then put my healing abutment, and I rolled the soft tissue to bulk it up. And this is at time 0 from before, time 0, and this is at actually almost 3 years in this case. And you can see the level of the bone. And this is another case, the one on the bottom. I'm going to show it next Tuesday, kind of in the complications. So that brings me to another kind of allograft use. So you can see here we have a defect, and we look at it again. You can see we have a defect, but we can't visualize exactly the amount unless you have the model in your hand. This is a technology that Straumann has, is the milling of an allograft, and you can see they make it, they conceive it for you. You send it. It takes 45 days. And then you do the case. This is, I did an extraction of the number 19, let the soft tissue heal. And there's a reason, look the closeness of that root here. So I wanted to let it heal. And then when I came to the surgery, then I had the block pre-made. So I really needed to do a little bit of adjustment here. And then I secured it with 2 screws. And I put the membrane on top of it, the resorbable membrane. That's the Straumann Flex, is one of my favorite membranes. And then I take an X-ray time 0, and this is at 9 months. You can see the mineralization of the graft, the height that we gained in here. And now the most important is this sagittal. You can see the amount of new bone that we have formed. From 3, we went to 11. And we look at it clinically, you can see the bone. Look at the tacks where they are below the graft, and it's a beautiful bone. And then we placed those 2 implants. Unfortunately, she was one of my assistants, and she had a problem with her ankle. She hasn't been back for 2 years, and she came recently. I took an X-ray before the coronavirus thing, and she's going to have the restoration done. But this is a 2 years follow-up, and it's really beautiful bone. So that brings me to the last case here, and this is a complete fracture and destruction of the 2 premolars. So when you print the model, then you can see the amount of damage that we have. And what I did is I waxed the area to see the amount of bone that I have to put. And then I prepared the titanium mesh. It's one of my favorite titanium mesh. I fall back on it a lot. I don't use membranes on it, and I use it medical grade. These are medical grades, and you can see the flap is the same incisions, more to the buccal, intrasulcular, slicing, intrasulcular here, more to the buccal, same thing, and full thickness. If I need to do anything, I'll do here a submarginal incision. And then I elevated the flap. Here you can appreciate the defect in that area here, the extraction that we did. And now we go ahead and I place my allograft. It's 100% allograft, cancellous cortical, cancellous at the bottom, on the bone contact, cortical on top. I put the titanium mesh, you screw it on the lingual, you screw it and fold it back, and you close it on the buccal. On the socket, I just did a regular sandwiching also, cancellous cortical on top, and I used again a membrane. I tacked it, and we achieved primary closure. This is what I mean by the stretching. Look, there's no vertical incision whatsoever. If there is some fibrosis inside the flap, it doesn't stretch, then I remove that fibrosis. And if you look at my hand, you can see me with the camera. This is the flap. I section horizontally, not like this, horizontally. Once you remove the fibrosis, the flap will mobilize. Now, I published 2 articles on the flap, one with the titanium mesh results, one with a different flap design only for the flap. It came in January and of this year. And this, the temporary, fixed temporary, is very important. And now we go ahead and we look at the bone. Bone looks great. We take an intraoral scan. That's before we do that. And just to compare for you the two together, this is the before and after. I mean, and look at here, and this is with the soft tissue, and this is the sleeves. And now we 3D print the guide. But this is just to give you a lay of the land on the rendering. This is the two spots that we crafted. This is an immediate that we were going to do. And this is the guide. We were planning to add one more implant, but then it was not needed. And then we moved along with it. And now you can see when you open and you place the implants and also the immediate with the guide. And this is what I mean by my the second stage. I take the extra soft tissue here, I rotate it and I put it. I published a chapter on soft tissue management around the implant in Elsevier, a publication. And here you can see the implants at the time of the second stage. And finally, after 3 years of follow-up on that case. So you can see the stability of the bone, and you can also appreciate the emergence profile and look at the immediate. It helps a lot to use guided surgery when you are doing immediate. So this is the result of our titanium mesh study. We did it comparing the printed model versus the stone model to see how much the time saving was an average of 25 minutes. That's huge for us in surgery. And we found a good horizontal and vertical gain using 100% allograft with a medical grade, big pore, no membrane whatsoever. So with that, I like to end my presentation, which is what I call the Shahrisms. And when we went to the West, we went with caravans, as you recall the history. And then after that, we went in trains. And then from there, now we fly with this beautiful, beautiful planes like this A380, which I love. It's a great plane. It's comfortable. Look at the difference. Look how where we were and where we are today. And then I like to end it. That's why it is important for us to move along with the technology, not be afraid of it. The technology is there to be used, and it will make our life much easier. As we touched on Tuesday, it's huge about the communication with the patient, communication for us, like we based on referral with the referral. It's so much benefit out of it. Cross-contamination, all of these things, we can avoid them with doing the digital dentistry. And from there, I like to end it with a quote from Yogi Berra. He's a baseball player. I am not a big fan of baseball. I have nothing against baseball, and I didn't grow up with it. But this man is, he has a lot of quotes. He's a high school graduate, but in reality, he says a lot of things that comes out of his heart. Unfortunately, he passed away. He's from New York. And he said, I always thought things would stay the same until they changed. And it's true. From when I was in the 90s to where we are today, it's a joy to do anything in dentistry, even the restorative dentistry, which I don't, but I see how it progressed with time. It's fun, it's beautiful, and we can do so much with it. I know we're going through this crisis, and we talked about it on Tuesday, but it's just a passing by, and it will go. But we need to get prepared and move along with it. So on that, I want to thank Straumann also to create my second webinar for you. I hope that you enjoyed it. I look forward for your questions, and I'm gonna end it with this picture. I love the iron, flat iron building. I'm obsessed by it. If you've seen me before lecture, I always say it, but I wanted to share with you my contact information in case you wanna reach me via email or you wanna follow us on Instagram, Twitter, LinkedIn, and we can stay in contact.